Welcome. I am so excited to be here and be invited by Skills. My name is Patricia Wright, and I'm the National Director of Autism Services for Easter Seal. And so Easter Seals is a social service organization that provides support to many individuals with autism throughout the United States. And I've been invited today to talk about autism service delivery and evidence-based practice. And I really appreciate you joining. It's always fun to do distance education and distance delivery and have opportunities to interact with people from all over the country. So thank you again for joining. There's 3 learning objectives for today. The first is to verbally state a working definition of evidence-based practice. The second is to list a typical hierarchy for levels of research evidence. And the third is to be able to list 2 written resources that are available to guide evidence-based practice in autism service delivery. And we're going to hit each of those objectives during this learning opportunity today and be able to review them at the end to make sure we've met our learning objectives. So just a brief introduction. Again, my name is Patricia Wright. I work with Easter Seals, a social service organization, and I understand there's many people on the Skype call today. And so just a little bit about how you can engage in learning. Certainly learning is interactive. So if people participate in this learning opportunity, then the engagement will increase and learning will improve. So there is a chat feature that we're going to be using so to be able to type in some chat messages. And the phone etiquette for webinars is taken care of because there's a protocol that we've already done for that. And then you can also participate through some polling, and that will also be done through the chat feature. So whenever you see blue, like you can see on the slide now, it'll be an opportunity for you to engage with the learning. So as we all are starting to do more e-learning and distance learning, being able to engage with each other is really important. And it's fun to be able to see what other people are saying or what they're doing during the webinar as well. So the schedule, do a brief introduction, we're almost done with that. And then talk about evidence-based practice, talk about resources for evidence and autism, and then some decision-making tools. So introduction. So this is your first kind of poll, if you will. Just curious who people are and how what your role is currently. So you can type in whether you're an educator, parent or care provider, OT, speech pathologist, behavior analyst, or what else. So we'll just take about 10 seconds here, and you can go ahead and use your chat feature to type in what your roles are. Got behavior analyst, parents, excellent. It's always nice to have a mix of people involved. And some more parents, excellent. I'm not a parent, and I'm not a parent of a child with autism, so I always appreciate when parents are engaged in the process, and you guys signing on in your incredibly busy days. Very much appreciate your participation. I think most people have a clear understanding that anytime we're engaging in autism intervention, if we can do it collaboratively with family engagement, family involvement, paired with professionals, the outcomes are always more successful. So really appreciate parents being engaged. So first, we'll just talk a little bit about evidence-based practice, certainly a term that gets thrown around a lot. And I'm just going to read you a definition that I like very, very much from Sackett. And it says, the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based means integrating individual clinical expertise with the best available external clinical evidence from systematic research. And you can see the term patients there in that definition demonstrates that this definition does come from the medical model. And evidence-based practice really did emerge from the practice of medicine and from the medical framework, really wanting to use medical interventions that were the most effective. And now it's kind of influenced our practice in autism intervention and education, understanding that we really should be engaged in work that is effective and when we're engaging in treatments. I also like this definition here because I'm a strong belief in science, researcher by training, really appreciate having research to guide my practice, but it also requires our clinical expertise and using our kind of knowledge base as clinicians applied to that research. And we'll talk a little bit about why that's so, but there's the science and the research that we rely upon, but then we need to pair that with our clinical expertise to ensure that we're engaged in evidence-based practice. So why is evidence-based practice important? Evidence-based practice comes from 4 categories, if we think about it, as research, professional judgment, values and preferences, and capacity. And we'll talk about each of those 4. And then we'll just talk a little bit about, I'm sorry, I'm skipping a slide. Why evidence-based practice is important. Sorry, I am just going to check in. I'm looking to see which sequence it's in of my slides. Yes. Sorry to the people that are controlling my slides. I just went out of order. Why evidence-based practice is important, and that slide says evidence-based practice. Why is it important? And there's kind of 3 things that I think about why it is important. The first is we have an ethical responsibility to provide quality service, and that's first and foremost why it's important. It's just pure ethics. So as an autism interventionist, for myself, I want to be engaging in work that is effective and that provides the best outcomes for the individuals for whom I'm providing service. So I have an ethical responsibility to do work that can provide the best outcomes. And so just ethically, I need to be engaging in work that, again, has a scientific base. And then from my clinical judgment, I know that's going to be effective. The second thing that's important is some federal, state, local regulation. So we're seeing a lot of policies come through on autism treatment. Certainly when we're using autism as part of a medical protocol, a medical autism treatment for medical intervention, there's strong regulations on what we do and the interventions that we can use. And often those require us to use evidence-based practice. And the third is justification for third-party payers. So 31 states throughout the United States have autism insurance mandates, and we're starting to really understand our third-party payers from medical insurance providers. We also have developmental disability service systems. Those third-party payers are asking us as autism interventionists to use effective evidence-based practice. So I want to say that those are 3 important reasons. But for me, the most important is ethics. I think that we have an ethical obligation to ensure that individuals for whom we're providing service and the parents and care providers for whom we're educating about autism treatment, that we ensure that we're using practices that we know have the best chance for effective treatment. And then just curious kind of why parents actually choose to engage in evidence-based practice. And Remington did some interesting work here, and I thought it was important to kind of share, because I'm always kind of curious why people choose different autism treatments and why people choose to engage in different autism treatments, and how I, as an educator and a behavior analyst, can help people make choices about choosing effective autism treatments when there's so much information out there that people are trying to sift through. So first of all, some normative beliefs about why people parent people, and this research was on parents, but I think we could probably extrapolate to people, why parents believe in or choose to engage in effective practices. The normative beliefs are that they hear from parents of other children with autism that it's effective, that they hear from health and education professionals that it's effective, and that they also hear from the media. So parents who are using effective practices, and when we ask them, so why did you choose to use this practice, they talk about these things. And then from some behavioral beliefs, they've seen evidence of it being effective, also that it just made logical sense. So when people talked about the treatment, they were able to put it in a way that goes, oh yeah, that makes sense. We should do that. That's a perfect way to engage in treatment. Parents also appreciated that it offered hope, so that there was an opportunity for their child to improve, and that we were sharing information about the treatment was going to improve the quality of life for their child. and that it was available. And so when I think about why or how I can engage in conversation with parents and other professionals and why I'm trying to promote effective practices and evidence-based practice, I keep these in mind and think, gosh, how can I share information in the way that Remington has showed us here that actually will promote engagement in effective practices? So can I share information, have other parents share information with parents? Can I encourage the media to portray stories about effective treatment that has an evidence base? Can I offer hope? And can I make sure that it's available? Can I, ensure parents that they're going to have access to the treatment that's most effective? So what is evidence-based practice and what are the categories that we think about? Sorry, I just mentioned these before, but we'll go over them again. Research, professional judgment, values and preferences, and capacity. And we'll talk about each one of these. I think the first one that most of us think about is research. So we think, oh, evidence-based practice, and research makes us have evidence. Most of us in today's society, I call it the University of Google, but most of us often the first place that we go to do our research is Google and just do a search there. So I'm going to ask you here to take this next opportunity to participate and engage on the chat. The University of Google here, if you type in the word autism, how many hits do you get? More than 76 million, between 50 and 76 million, between 25 and 50 million, or between 0 and 25 million? And we'll take a couple minutes here for people to share their perspectives. Between 50 and 76 million was one guess, one answer. Thank you for participating. It's always great as a presenter to have interaction as well. So it's fun for me to see your answers pop as you're typing them into the chat. More than 76 million. Yep. There's a lot. And the person who suggested there, one of the individuals who suggested there, more than 76 million, that is indeed the case, that when you type in the word autism to just simply a Google search, you end up with more than 76 million hits. And so that was when I tested it out maybe 10 days ago or so, is more than 76 million. So what that does is, actually, it's the first thing I thought when I did that was I had incredible increased compassion for parents who are trying to understand this word called autism and how it affects their child when their child's been newly diagnosed. So I just thought, gosh, a parent comes home from a diagnostic appointment and they've received the information that their child has autism. They go to the computer, they type in the word autism to Google, and they get 76 million hits. And so what do you do with that? How do you sort through that? And then the next thing that I had, the next kind of awareness I had for that was, oh my gosh, I have such an incredible responsibility to ensure that I can guide parents through that information in a meaningful way. That when parents turn to me and say, oh my gosh, this is what I learned on Google, what do you think? How can you help me? That I have a responsibility to help them sift through those 76 million hits, because that's just the reality of where people go for information. And the fact that there's so much content out there is a great thing, but having to sift through to find the good content in that 76 million is a whole nother case. So again, those categories we talked about, so we have research, and then we have the research on the University of Google. But we also have research that we consider kind of from our scientific base and what we use for evaluating information that are kind of published in scientific sources such as journals. And there are many levels of research, and trying to kind of understand what the best research is and how we are able to use research and evaluate research at the different levels. And what you see here are kind of 5 layers based in hierarchical order of research that we would look at from within the field of kind of scientific inquiry. And the first highest level of research are randomized controlled trials. And these are very commonly done in the field of medicine. It's how most medications are approved for use within the general society. And randomized controlled trials is, we have people that are randomly assigned to two groups, and we try out an intervention. One that gets one intervention, and one that either is a control or gets another intervention, and we see what happens. And that's the highest degree of scientific rigor, is the randomized controlled trials. And it would be great if we could, look at autism treatment within randomized controlled trials as well. They're very difficult to do for lots of reasons. It's difficult to randomly assign people within the autism spectrum, since there's such a wide variety of variability within autism. They're often can be very expensive to conduct. Just randomized controlled trials can be really difficult. We have a few of them, and that's great, but they're quite difficult to use within the kind of social science or social service field research. The next thing we have is comparison groups. And again, you have one group that gets an intervention and one group that gets another intervention, or a group that gets a control, no treatment, but they're not randomly assigned. And that's fantastic research as well. So we are able to look at outcomes from the comparison group research and make some decisions about what we think is going to be more effective. We have many studies that are comparison groups within the field of autism and education. And so we have some good information from there. We have pre-post comparisons, which means we look at a group of individuals or an individual before an intervention and after an intervention. And in many ways, this is the bulk of the research we have within autism. So we look at pre-post comparisons. And again, solid research, but you can see as we're kind of moving down the levels that we're decreasing our scientific rigor, and we're decreasing the knowledge that we might be able to feel strongly about from these levels. The fourth is correlation studies. This is retrospective. So we look at a group or some individuals, and then we look back historically and see kind of what happened to them, or what were they engaged in, and we make decisions. This is again lower than the three above. So correlation, kind of looking at people after something happens and trying to kind of review and correlate some of what happened to where they are now. And the last research is case studies, anecdotes, expert opinions. And that is research, and that's often where research starts out, where information starts out. It's someone does a case study and it's interesting, and we want to see if with increased scientific rigor would that happen. And so we kind of move it up the scale of scientific rigor. So randomized control trials, again, we wish that every autism treatment and every autism intervention could go through that randomized control trial. It's not really reality, so we end up going down the levels further and trying to make information, judgments and information from those next levels. So just to give a little external validity to some of these levels of research and how we think about it, because again, we all wish that we had randomized control trials for everything. But the next poll is, what level of evidence do we have that smoking causes cancer? Do we have a randomized control trial? Do we have comparison groups? Do we have pre-post comparison, correlation studies, or case studies, anecdotes, and expert opinion? And again, you can see it's blue there, so engagement would be delightful. And go ahead and type in your answers in that chat feature. Randomized control trials, someone thought. Take another minute, about another 10 seconds or so to type in what you think is the case. Case studies. Yeah, we have a kind of a range of correlation studies. Yeah, we're kind of all over the map on this one. So if we had a randomized control trial for smoking, what that would mean is, we'd have a group of babies born, and we'd randomly assign one group to become smokers and one group to not, and be able to look. So we certainly don't have that. Comparison groups would be, again, we wouldn't randomly assign them, but we would just have a group, and some would smoke and some wouldn't, and we'd be able to look at them before and after. Pre-post comparison, we don't have that either, because what happens is no one goes in for a medical assessment before they start smoking to share with their physician, I'm now going to start smoking, so let's do all these tests, and then post, you can look at me afterwards. So what we actually have are correlation studies. is we simply have correlation. We've got a lot of people who smoke, and we correlate it. We look back to see about their smoking. And this is for humans. We go back and look, and we've correlated smoking with cancer. And I say that because I think most of us here in the United States would agree that there's, smoking is absolutely associated with cancer. And we can say that with strong conviction. But the best research we have to talk about that is correlation. And I share that with you because I think sometimes within the autism treatment and autism intervention, we always want to hold the highest rigor, but sometimes we don't have that level of evidence. And we don't know everything about autism treatment yet. And we don't know, exactly what's going to work for each individual with autism. And so it would be great if we knew that the best evidence that we could use were effective for each individual child, but we don't know that. And sometimes we have to rely on lower levels of evidence to make decisions. So just kind of sharing that relation with smoking, because we have amazing amounts of correlation that have educated us who are not in the field of public health and smoking behaviors that make us feel strongly that smoking is associated with cancer, or smoking even causes cancer. We'll hear people say that, although we don't know that. We just know that it's correlated. So thank you again for those who are typing in answers. It's really fun for me to see them popping up. I know people are out there writing, so that's great. So the research another component of research that we need to think about as far as evidence-based practice is the applicability to your population, environment, and circumstances, and also how far we can extrapolate. So my work with Easter Seals, we work in urban environments and rural environments, and we work across all kind of cultural and ethnic diversity that we have here in the United States. And we work with families who are single-parent households and people that live in multi-generational households. So there's a lot of different environments that we all work in as autism interventionists, and there's lots of different ways that families who have individuals with autism are made up as well. So it's nice sometimes when I can pull a research study and I can go, oh, excellent, here's an autism intervention that worked in an urban environment that was for individuals of this particular ethnic minority. Isn't that great? If I'm going to apply it in an urban environment with a particular ethnic or cultural minority. But we often end up having to extrapolate. So there's not a lot of research that's done in rural and remote areas. And so sometimes when we look at interventions, then we go, oh, this is such a great intervention, but we find it was done in Baltimore, Maryland. And the people that were able to provide that intervention also lived in Baltimore, Maryland, and they were able to go to the individuals' houses, 3 times a week. And I think, oh, I'm not sure how that's going to work in rural Montana when, it's 4 or 5 hours drive to that person's house to be able to provide that intervention for the professional. So I have to extrapolate. I have to make some decisions based on the population and the environment and the circumstances. So again, sometimes it's easy to say this is the best intervention from what the research says, but that's also where that clinical judgment comes in, and we have to make some decisions. And what's the applicability of that research to the environment where we're currently working? So research is important, and we have to be looking at the evidence. And to be honest with you, I would rather have a research study that tells me what's going to promote a best outcome in Baltimore and be able to think about how to extrapolate that to rural Montana than to just be kind of shooting in the dark. But I do have to go through that work of thinking about how it is going to apply, or how we are going to implement with fidelity and use that intervention in a different environment, perhaps with a different population. So research, I chose to speak about that, number one, because I think it's our first go-to. When we're thinking about autism intervention and autism treatment, the first thing we think about is our research base and what the science tells us about what's going to be most effective. The second thing, and as we saw from that definition, is professional judgment. So professional judgment is the judgment of the professional with expertise pertinent to the question or the issue. And this is an important thing as well, just to think about what constitutes clinical expertise. I laugh sometimes because people will describe me, they'll go, oh, she's an autism expert. And I always kind of laugh. I'm like, oh, careful, because I know some things about autism within some categories. But if you ask me to review the genetic predisposition of autism, I'd be hard pressed to provide any degree of eloquence on that topic. So my expertise is limited in scope, and I'm able to talk about autism intervention, autism treatment, within specific age groups, within specific categories of autism intervention. So, we have to think about what constitutes clinical expertise. We certainly have degrees and certifications that help guide people to help their belief system, to find people that we perceive as qualified. But degrees and certifications can help. But it's also about opportunities to engage in that practice, not just your professional training, and having knowledge base from experience as well as your degrees and qualifications. And then the clinical reasoning for how you can or cannot apply the most effective intervention for a given client. So in order to make a clinical judgment to not use the most effective treatment that the evidence base says, you have to know what that treatment is, and you have to be able to just explain why you're not choosing it. And I often think about this related to medicine and medication. So many physicians prescribe will prescribe a second tier choice for a medication. For example, treatment A may be the best treatment for tuberculosis, but it requires that you take, medication, let's say 4 times a day on schedule. And the physician may be looking at this patient and saying, gosh, I don't think they're going to be able to do that. I don't think they're going to be able to follow that treatment schedule. So I'm going to use intervention B. I'm going to use medication B because that only requires a single dose per day. And we can help the person, be more successful. Still an effective treatment, if you will, but it's not as effective as treatment A. So sometimes we make that same decision with autism treatment. We think about an intervention, maybe it's a high degree of intensity. Maybe it requires, many, many hours of intervention for the family. And the family's just not able, given their circumstance, to be able to have people in their home for that many hours per day, or to utilize that intervention perhaps because some of their cultural norms or their cultural beliefs. So, we have to be able to understand that and say, oh gosh, well, and provide informed information to the families with whom we're working. But to say, gosh, intervention A would be great, and that may be the best evidence we have, but I don't think that we're going to be able to do that, and we're not going to be able to use it for this reason. So we're going to move to intervention B. But in order to do that, you have to know what the evidence is. In order to move off of the best practice, you have to be able to know what the best practice is. And that sometimes I think that's missing from people who are engaged in autism treatment is they might prefer or they might like an autism intervention that has a lesser evidence base, but they haven't become familiar with the intervention that has the strongest evidence base. So that's kind of an ethical dilemma for individuals when they're utilizing professional judgment to inform their practice. First, you have to know what best is before you can decide to use what may not have the best evidence. The third component of evidence-based practice is values and preferences. And there's 3 areas that we consider regarding values and preferences. And the first is the individual for whom we are providing service or for whom we are providing intervention. Their values and preferences are of the foremost concern. It's interesting when we're working with very young children because we often default to the second category first, parents, significant others, and family. But I have strong beliefs that first and foremost, we have responsibility to the individual for whom we're providing service. I provided a resource there, Hanley's research from 2010, demonstrated that children in preschool, children age 3 to 5, were able to demonstrate how they preferred their intervention to be delivered with some manipulation. So they were able to manipulate some rooms to say, this is how intervention, the red room's going to provide intervention in this way, the blue room's intervention, and then the yellow room. And individuals were able to say, oh gosh, no, I want to be in the red room. That's how I want to learn. Or no, I want to be in the yellow room. That's how I want to learn. And so even very, very young children, given opportunity, can make choice and have their values and preferences considered in autism treatment. I encourage you to look at his work. The second category are the parent and the significant others in the family. for whom we're providing service. So individuals, and then their, ongoing support community of their family and their parents and their values and preferences are considered, what makes sense for them. And then finally, the care providers, people like me, people who are engaging in the intervention and the treatment. So finally, it's the care providers. And sometimes because we come to the table maybe with a little bit more knowledge base about autism treatment, we need to be careful that we're not jumping over those primary individuals and families with our beliefs. So most of us who've been engaged in autism treatment have strong beliefs about what's effective, and we know what we think should work. But we also need to provide opportunity for the individuals we're serving and their families to make decisions with information. And again, back to that 76 million Google hits, they need to have the opportunity to ask questions, share information about what's important to them, and what information they may have or questions they may have about autism treatments before we kind of assert ourselves and our beliefs into theirs. So this next one, you can chat if you would like. I just think it's important for us to at least think about our values and preferences. And I will tell you that one of my strongest values, my personal values, is equity. And I really, really struggle when families for whom I'm providing service aren't experiencing equity. We know there's strong disparity in our society between kind of the haves and have-nots. And there's disparity between people who can receive quality intervention and those who don't. Often it's socioeconomic disparity. Often it's people who English isn't their primary language here in the United States. So equity is one of my very strong values that I struggle with when I see sometimes things that are inequitable and my values end up being kind of usurped. The other value, and again, you're welcome to chat your values and preferences if you want. It's a personal decision. The other value that I struggle with is I have a strong belief around independence. And being raised kind of here in North America, we have a strong belief around independence. So you're supposed to do it for yourself, and everyone's supposed to become independent. And I've worked in cultures where independence is not as valued as it is from my belief system. So I have, a strong, pushback when people say, "Oh no, they don't need to be able to do that because their brother will do that, or their community will do that, or their family will do that." And I often want to be able to say, like, well, what if their brother's not around, or what if their family can't do that? And that's my belief system coming into play too. I've worked in both the Native Alaskan populations and the Native Hawaiian populations, and they have really strong beliefs around community that are different than mine. And I often find myself at odds with my belief around independence and their belief around interdependence and opportunities for communities to work together. And so that's something that I've had to have a lot of dialogue with people about to see if is it really my belief, or is it actually something that's truly important and a value and preference of the individual? So 2 people typed in a similar one that I have: high quality intervention and proven interventions. I am right there with you. So I struggle when people make informed decisions to maybe engage in intervention that's not as effective. I have a strong belief in scientific inquiry, and I have a strong preference for using practices that have a scientific base. And sometimes my values interfere when I'm working with maybe families or other care providers that have made decisions that I think are not of the highest degree of scientific rigor. So I'm there with you on that. The proven interventions is something that's important to me. So we've talked about research, we've talked about professional judgment, and then values and preferences. The fourth category that we're going to talk about regarding evidence-based practice is capacity. So again, you can have the best intervention in the world published in the great journals. I can think it's the best thing since sliced bread, and it's the value or preference of the individuals for whom we're providing service in their community. But if we don't have the capacity to deliver it, then that's a difficult barrier to overcome. Talked a little bit about geography being a barrier at times. but also proper training and professional development. So in order to deliver interventions, many interventions require very specific training. And it's not just attending trainings, but it's also having the opportunity to have coaching and modeling for those interventions. So I see a lot of school districts and departments of health and departments of social welfare that are really committed and want their staff to be trained in high quality interventions. But it's really hard. If we can do trainings in big groups, it's somewhat easier. But then in order to take those and put them into practice, we know that you have to have coaching and modeling. So to really have the capacity to deliver training, we need to make commitments to that coaching and modeling as well. Adequate resources, adequate staff resources, adequate material resources. So when we pull some research and the intervention maybe requires, a high-speed internet connection and, a fairly modern computer, do we have the adequate resources? Can we implement that practice if those resources aren't available? And then, of course, all of this is related to ongoing feedback about treatment fidelity. So those of us that are interventionists are well familiar with the experience of drift, and you can be incredibly well trained, and you can be implementing something with fidelity. But if you don't continue to assess your practice, then we end up with drift. And then our treatment, we're not delivering it with fidelity. Some of us can use independent video modeling for, videotape ourselves and provide ourselves independent, feedback on that. But it also goes back to coaching and modeling, that most of us need ongoing support to ensure that we don't have drift in doing that. So those four components that we just talked about are all part of evidence-based practice: research, professional development, professional judgment, values and preferences, and capacity. And in some ways, I think the research is the easy part. It's pretty, if you have opportunity to read our professional journals on autism and have access to them, it's sometimes it's great. We can just say, oh, this is the best. This is the best intervention. It's when you start kind of overlaying those other categories that it can be more difficult. What's your professional judgment about the ability to use this great research in practice? What are the values and preferences for the individuals for whom we're providing service? And then finally, what's our capacity to actually do that intervention in the field where we're working? So the next category we're going to talk about are kind of resources for evidence and autism. And I'm happy to share that there's two great resources that we'll talk about. But I'm just curious, where do you turn for information? Again, we talked a little bit about Google. That's a place where many of us go. But where do you turn for information? And go ahead and put that in the chat feature. Someone stole my thunder. We're going to talk about that next. Someone just said National Standards Project. Indeed, that's a great one. Where else do people turn for information? Scientific peer-reviewed journals. Absolutely. Many of us who are in the field have used our peer-reviewed journals for resources for our research. And centers of excellence. Excellent. Books, you bet. Thank you guys again for typing in your answers. Conferences. This is a popular one. Workshops. Super. Yes, all of these are great resources. So what people have shared here are National Standards Project, Scientific Peer-Reviewed Journals, Centers of Excellence, books, conferences, workshops, Autism Speaks, peers, other BCBAs. Yep, and engaging with some of our peer learning. So, again, kind of the same levels of evidence we talk about. Some of these are of the same caliber within those. All of them are worthy. It's a matter of how we evaluate them and how we put them into practice when we're looking at the information we're getting. It's great to attend a workshop if the person is a reputable character and providing information that has a base somewhere, maybe in the scientific literature, or somewhere higher in that degree of evidence. But sometimes workshops are not of that caliber. but we still, sometimes we still end up going because I'm always curious about the information they might be sharing. But you're right, that's where lots of us go for information in different sources. Someone mentioned, I'm going to talk about 2 resources that are available that I think are fantastic for resources for evidence in autism. The first is the National Standards Project. It was initially published in 2009. There's been some additional resources that have been developed by the National Standards Project, but the first push of their content came out in 2009. I think that's important to think about as it's getting kind of, on and on in years. So if it was published in 2009, then the literature review stopped before that. The National Standards Project looked at educational and behavioral interventions that were published for individuals below age 22. And they did an incredible, what's called a meta-analysis. They looked at the literature and all the things that were published out there and in peer-reviewed journals. They did the hard work for us. They looked at all of that work, reviewed the literature, and came up with some consensus and some rules around what was considered high quality and evaluated that for us. And they came up with 4 categories of interventions: established, emerging, unestablished, or ineffective and harmful. And you can see that the number of treatments they came up there, 11, 22, and 5, 0 for the last category. And, for me, what feels really comfortable when I'm looking at the National Standards Project is to be using those established treatments, those 11 established treatments. And then as I spoke about before, sometimes my professional judgment and capacity and values and preferences ends up resulting in using some of those emerging treatments. I certainly feel pretty confident saying that we don't need to be using unestablished treatments, and they didn't actually find any that were ineffective nor harmful. So this great meta-analysis, I encourage people to just Google, our friend Google, National Standards Project, and you can see what those treatments are. I've put the 11 here that are resources for evidence in autism: antecedent package, behavioral package, the list there. And you can see that many of them are packaged afterwards, which means that it's kind of a multi-component intervention. I think they've delivered the information in a very user-friendly format. It's accessible to those of us who have a strong grounding in autism treatment, but it's also intended to be accessible to parents and care providers and perhaps professionals that have less background in autism intervention. It's available, I believe it's still available for free. So they've just done an incredible service for us, National Standards Project. It came from the National Autism Center, and they did a really nice job of evaluating the literature. And again, it was published in 2009, so there has been additional literature that's been published that didn't make it into that review. So we just need to be thoughtful in how we're using that information. The second resource that I want to talk about for evidence in autism is the Professional Development Center in Autism Spectrum Disorders. It's a 5-year nationally funded project, federally funded project. It was awarded in 2007, and the work is ongoing. And they currently have identified 24 practices that are evidence-based. This is where some of the confusion comes in, and you can imagine how people who have kind of a lesser autism treatment background, how come one has 11 and one has 24? I'll share a slide with you that kind of crosswalked those, but you can imagine where some of the confusion lies is people look at one meta-analysis, and then the Professional Development Center in Autism Spectrum Disorder did another meta-analysis, and they have 24 treatments. And the good news is it's still ongoing, so their work is continuing, so the literature base is fairly current. The other really great thing that the Professional Development Center has done is they have partnered with Autism Internet modules, and so there's learning modules that have video components for those identified treatments. So if you, again, type in Professional Development Center and Autism Spectrum Disorders and get there, as you click through, you can get to the Autism Internet modules. So the learning is interactive and engaging to learn about what these practices are. Their site is rich in resources. It's primary site is University of North Carolina, Chapel Hill. The Wiseman Center and the Mind Institute at UC Davis are also involved in the Professional Development Center. When you go to that site and you get to their evidence-based practice section, there's evidence-based practice brief. There's the components that are there, and there's an overview. There's step-by-step direction for implementation. There's implementation checklist, and there's the evidence base. It's nice for me. I like to go there to see the literature review that they use and the studies. Sometimes if I want to go back to the direct source for something, for one of the used practices, I like to go back to the original and see what the original data are. So Professional Development in Autism Spectrum Disorders has an incredibly wealth of knowledge on their site about it. It's an ongoing meta-analysis. I want to do a quick activity. If you look here, that's kind of the evidence-based practices from the list there. If you just go to the next slide, it says resources for evidence in autism, what you do, what you know about, and what you might want to learn about. So on a piece of paper next to your desk or something, just make those 3 boxes: do, know, and learn. And just kind of give yourself a little room to put hash marks and or fill in a little bit of words there. And I'm just going to read off a few of these treatments from the National Professional Development Center and Evidence-Based Practices. And what I want you to do is put a check in the box if you do it, or put a check in the box if you know it, but maybe you're not doing it. And then also to write it down if it's something you want to learn about. And then you can have a call to action, and you can, after we finish this course, you can go to the Professional Development Center on Autism and take a look and see about something that you want to learn about it. So I'm just going to read a few of them. I won't read all 24. So again, put a hash mark if you do, hash mark if you know, or write it down if you want to learn about it. So how about extinction? Do you do it? Do you know it? Or do you want to learn about it? Naturalistic intervention. Again, do you do it? Do you know it, or do you want to learn about it? Prompting. Discrete trial training. Time delay. Visual modeling. Do 2 more. Computer-aided instruction. Social narratives. So again, you should have a little grid there with do, know, and learn. And you can go back and actually look at the National Professional Development Center on Autism Spectrum Disorders and look at all 24. See if there's one perhaps that you're interested in learning about. I know one of the ones when this first came out that I was less versed in was peer-mediated instruction, which is an evidence-based practice. And I took that opportunity to learn about it on the site, to do the literature review, and then also to go to the Autism Internet module and engage in some interactive learning about it as well. So I've really appreciated this site. And again, it's a rich professional development opportunity online that they've established for us. So hopefully you have one perhaps that you want to go back and learn. And when we finish this one, you can take it at your leisure, take the opportunity to go do that. If you want to share, you could put what's on your learn list. Sometimes when we write it down, right, it makes it real. So you can, again, go ahead and use your chat feature if you want and say what was on your learn list. I'm just watching people type now because it's fun. Pivotal response training. Yeah, that's one that's got such a rich literature base, right? But a lot of us haven't had direct training in it. So that's absolutely important. And an opportunity, there's some training institutes. Verbal behavior approach. Yep, opportunities for learning and lots of those. It's interesting, those of us, I've been in the field for almost 3 decades now, and I am forever having the opportunity to learn and develop skills in areas that that I need. Okay, so the grid that you see now, resources for evidence in autism, the National Professional Development Center did a nice crosswalk from the National Standards Project to the National Professional Development Center in Autism Spectrum Disorders. So they have kind of put those two together. It's a nice kind of handout or nice kind of grid to look at if you're kind of trying to figure out how to explain to people, well, how come it says this here and it says that there? You can kind of look at this and kind of crosswalk it together and see where some of the disparities are, and really much more how much they're alike and how much the wording is just a little different. So in closing, just want to review our learning objectives. So I was hoping that through our time together, you could verbally state a working definition of evidence-based practice. I'd like to hope people think across those 4 categories. So when people ask me, what's an evidence-based practice? I say, it's grounded in the research when we apply our professional judgment to it while considering people's values and preferences and our capacity to deliver it. So evidence-based practice takes into consideration those 4 categories. You could list a typical hierarchy for levels of research evidence. So gold standard, randomized controlled trials. We wish all of our intervention research was there. We then have comparison groups, pre-post, correlation studies, and then lastly, we have case studies and anecdotes. So it is all research, but we want to be thinking about it from those levels of research. And then list 2 written resources that are available to guide evidence-based practice in autism service delivery. So we have the National Standards Project, which one participant was already super familiar with, which is great. And then the other one is the National Professional Development Center in Autism Spectrum Disorders. And both of those are easily found via the internet. And I wanted to make sure to end, we have about 5 minutes. So people may have been typing in questions, and people are certainly welcome to ask questions now as well. I certainly thank those of you who joined and need to move on throughout their day. It's been just a pleasure to be part of the program with Skills here and be invited to present. So I'll just hang on for a few minutes if people want to chat in their questions. This is good. Sometimes it is, I'll read the question, sometimes it is difficult to decipher which journals publish good work versus those that will publish anything. Are there any particular journals that are more trustworthy than others for publishing research as evidence-based? So yes, and I'll give you my bias for that, but there also is an unbiased or one that every journal or most journals that are reputable have what's called an impact factor. So you can look you can look up impact factor of a journal. The higher the impact factor, the better the work that's published within that journal. I think, within autism, I think there's a handful of journals that most of us rely upon. Research in Autism Spectrum Disorders, Journal of Autism and Developmental Disability, Other Developmental Disabilities, are 2, Journal of Applied Behavior Analysis within the ABA field. Certainly the Journal of Speech, Language, and Hearing from the Association of Speech and Hearing American Association of Speech and Hearing. There's those, but the impact factor is actually the unbiased measure of reputability of a journal. But I think that there are some that are good, better than others, and it's hard to evaluate. So next question is, what does a treatment have to go through to become deemed as evidence-based? So the National Professional Development Center in Autism Spectrum Disorders, actually, when you hit their face page, they have a blue box, and it tells you very specifically what their criteria is for evidence-based. So they have, it goes kind of based upon those levels of evidence. So is there a randomized controlled trial that was been done? Were there, enough pre-post studies that would indicate, or enough single subject studies done that we can say there's an evidence base. So the National Standards Project also had their criteria, and it's published in there. But there's usually kind of a criteria that's acceptable or accepted based on those levels of evidence. And then we're able to kind of say those categories are met. And within those meta-analyses, we say it's an evidence-based practice. Two more questions I've got. Why is there nothing on the ineffective harmful list for the National Standards Project? So based on their criteria, this is a great follow-up question. So they base their criteria on what would be considered ineffective or harmful. So you or I might say something like, intervention X was deemed to be ineffective, but they based on their criteria, they did not find anything that was deemed ineffective. And remember, they were only looking at educational and behavioral interventions. So something like secretin would be a medical intervention, so that wasn't reviewed. So some of the interventions that we may consider to be ineffective or have been assessed to be ineffective wouldn't have made that review be ineffective or harmful, but you should go back and look at their criteria of why nothing actually met it to be ineffective or harmful. And then why isn't more research being done on alternative non-evidence-based treatments, yet they are still being used to treat children? I know. It's interesting. Some of it is just research. There's just not enough research dollars to go around on autism treatment. So many researchers are most interested in kind of forwarding the field, and they want to, this is, Patricia Wright opinion, are forwarding the field. So they want to do treatments that are effective and make them even more effective. And to go back and look at treatments that are non-evidence-based are a little more challenging for researchers, because in some ways they're just kind of disproving it. It is interesting, some of the National Institute of Health dollars have been looking at things that were kind of alternative. They just announced, and I'm saying kind of alternative, I don't know, there's an absence of evidence, so I don't know if it's going to work or not, but they just announced funding for stem cell research. They've done some research for hyperbaric oxygen therapy. So there are some things that are being done, but most researchers are interested in advancing the field sometimes versus disproving things that they perceive aren't going to work. So it's certainly wide open for research to be conducted. So that was the end of the questions. I thank you guys very much for spending this hour with me. Thank you for those who typed in their queries and their responses. It's really fun to be able to interact with people from around the U.S. And be able to share information with each other. So thank you very much, and have a great day.